A cardiovascular event in middle age rarely happens without a long, silent incubation that begins before we are even born. Standard medical practice often treats atherosclerotic cardiovascular disease, or ASCVD, the buildup of plaques in arterial walls, as an acquired condition of aging. We monitor adults, prescribe medications in their 50s, and manage the decline. But extensive post-mortem investigations and longitudinal cohorts show a different timeline. The accumulation of cholesterol in our arteries spans decades, and its origins trace directly back to fetal development. This graph maps the cumulative atherogenic burden. The x-axis tracks a person's age, and the y-axis tracks their concentration of low-density lipoprotein, or LDL, cholesterol. The red shaded area under the curve is the total lifetime exposure of the arterial wall to these circulating lipids. By mapping the physiological trajectory of plasma lipids from the moment of birth, the data reveals that a person's lifelong cardiovascular risk trajectory is largely established by their second year of life. Recognizing that the foundations of heart disease are laid in the cradle forces us to rethink the precise timing of clinical intervention. The neonatal period is defined by rapid physiological adaptation to extrauterine life. To map exactly how our metabolism adapts, researchers in the Copenhagen Baby Heart Study analyzed a massive dataset, drawing 13,354 umbilical cord blood samples to track early lipid trajectories. This chart plots the trajectory of three major lipid parameters from the moment of birth. Notice the origin point. At delivery, concentrations of total cholesterol and LDL cholesterol in umbilical cord blood are significantly lower than what we see in adult populations, but those levels do not remain low. During the first 2 months of life, the lines for atherogenic traits like LDL cholesterol, non-HDL cholesterol, and apolipoprotein B, a protein that carries fat through the bloodstream, angle sharply upward in a stepwise increase. By the 14 to 16-month mark, the lines plateau. They reach a steady state that runs perfectly parallel to the horizontal band representing the adult maternal baseline. The infant's lipid profile is now statistically indistinguishable from a mature adult. These early measurements carry immense predictive weight. Infants born with lipid concentrations above the 80th percentile at birth maintain those exact high-risk trajectories firmly into their second year. An individual's lifelong baseline for plasma lipids is cemented essentially 12 to 16 months after birth. Their metabolic angle is set. To understand why some infants start with elevated levels, we must look at the maternal environment. Fetal cholesterol requirements are met through active transport across the placenta, a highly regulated cellular exchange. Data from the Fellis cohort in Naples shows that maternal hypercholesterolemia, high maternal cholesterol during pregnancy, acts as a direct stimulus for atherogenesis, or plaque formation, in the fetus. This maternal influence operates through fetal programming. High maternal cholesterol drives epigenetic mechanisms, such as DNA methylation, where chemical tags bind to fetal genes. This physically alters the expression of genes responsible for cholesterol homeostasis in the offspring. Yet this pathogenic exposure in utero operates differently than the high-fat environment of infant feeding. Clinical observations consistently show that breastfed infants have higher concentrations of total cholesterol and LDL cholesterol compared to formula-fed infants. This early dietary exposure is entirely normal. The high cholesterol content of human milk generates a salutogenic, or health-promoting, physiological response. The infant relies on these circulating fats for rapid cell membrane synthesis and the formation of myelin, the protective sheath around nerve fibers. Maternal hypercholesterolemia inflicts structural, epigenetic damage on fetal arteries, but the fat-rich diet of a nursing infant provides the exact necessary building blocks for early brain development. Blood markers give us a probability of risk. Physical pathology gives us the ground truth. Arterial damage is visible long before adolescence. A nationwide autopsy study conducted in Japan examined the aortic tissues of subjects ranging from 1 month to 39 years old who died of non-cardiovascular causes. This cross-section illustrates the findings in the infant aorta. The highlighted microscopic accumulations in the intimal layer are fatty streaks, clusters of lipid-engorged macrophages known as foam cells. The study found these lesions in 29% of infants younger than 1 year. The trajectory of these early lesions was mapped by the pathobiological determinants of atherosclerosis in youth, or PDAY study, which examined individuals aged 15 to 34. The investigators found that American Heart Association grade 1 and 2 lesions, the isolated foam cells and initial fatty streaks we saw in infants, are completely ubiquitous in the aortas of 15 to 19-year-olds. This dual bar chart compares the prevalence of advanced AHA grade 4 and 5 lesions by gender. These are fibrous plaques with an active lipid core. Notice the sharp exponential curve in the male population, jumping from roughly 2% in teenagers to over 20% by early adulthood. This structural decay is sharply accelerated by modern metabolic threats. The rising prevalence of childhood obesity serves as a catalyst for metabolic syndrome, a cluster of conditions including high triglycerides and impaired glucose tolerance. The physical architecture of a midlife heart attack is actively constructed and visually identifiable in the arterial walls before a patient is old enough to drive. These pediatric autopsies correspond directly to adult clinical outcomes, a link confirmed by multi-decade epidemiological tracking. The Bogalusa Heart Study in the United States and the Cardiovascular Risk in Young Finns study followed cohorts from early childhood deep into middle age. Both studies reached the same definitive conclusion: childhood lipid levels track with extreme fidelity. A high cholesterol child almost certainly becomes a high cholesterol adult. This continuity is driven by the biological reality of vascular memory. As the intima media layer of the arterial wall thickens and stiffens, it permanently stores the metabolic insults of youth. Childhood measurements of LDL cholesterol directly predict the thickness of an individual's carotid artery walls, known as CIMT, 20 to 30 years later. Because of this memory effect, cumulative exposure to high cholesterol at a young age increases the risk of developing carotid plaques completely independent of the patient's cholesterol levels in adulthood. Elevated childhood lipids leave a physical scar. Attempting to lower cholesterol only after a patient reaches their 40s is biologically incapable of reversing the structural damage already cemented into the vasculature. The calculus of cardiovascular disease is ultimately a function of time and volume, the total arterial exposure to atherogenic particles over a lifespan. This graph of the cumulative atherogenic burden highlights the window of opportunity. It lies within the first 2 decades of life. If clinical intervention forces this secondary trajectory line to drop sharply during childhood, it drastically reduces the total red shaded area under the curve for the rest of the timeline. To leverage this window, the American Academy of Pediatrics and the American Heart Association recommend universal lipid screening for all children between the ages of 9 and 11. However, for families with a history of early cardiac events or suspected familial hypercholesterolemia, a genetic condition causing high LDL from birth, clinical screening must begin as early as age 2. The immediate primary intervention is the Child 1 lifestyle diet. This protocol strictly limits saturated fats to less than 10% of daily calories and advocates delaying the introduction of solid foods until at least 4 months of age. While pharmacological treatments like statins remain a critical tool for severe genetic cases, the primary goal is primordial prevention, stopping the conversion of initial fatty streaks into calcified plaques before the process accelerates. Ideal cardiovascular health is a condition granted to most at birth. To meaningfully reduce the global burden of heart disease, the clinical effort to protect that baseline must begin in the cradle.